What happens if we flip the traditional way of sharing medical information to the wider population on its head? What happens if instead of letting algorithms or the zeitgeist of the moment order our social media feeds, we go straight to the source of clinical medicine and ask practicing experts what they see day in, day out, and give them an unedited platform to help disseminate practical medical information straight from the specialist? Thank you, Anton Emmanuel, as a professor, for coming today.
Pleasure.
Would you mind giving me an introduction?
Yeah, of course. So I'm called a neuro-gastroenterologist. I'm trained in neurology originally and became a gastroenterologist during my PhD. And now my current practice is a mixture of academic and clinical, and work in Queen's Square, the National Hospital for Neurology and Neurosurgery, and UCH. And my academic affiliation is with University College London. And most of my work is with patients who have neurological illness and gut dysfunction. But a lot of the research I've done over the years has been in that population, as well as patients with so-called functional gut disorders like irritable bowel, chronic constipation, fecal incontinence, and trying to offer tailored treatment.
Fascinating. So you're saying that actually there are clinicians, so it's not just that we know of this thing, the brain-gut axis, but now you're saying that there are clinicians like yourself who practice specifically with the brain-gut axis.
Yes, I think it's one of these things which is people don't necessarily declare themselves about. I think within the neurology world, we're certainly used to the idea of chronic neurological diseases manifesting in all sorts of different systems. In the gut world, we've emerged with this idea that there's a sort of a mini brain in the gut, and that makes sense anatomically in the sense that there's 100 million neurons in your gut, more than there are in your spinal cord even. All the neurotransmitters that conduct stuff in your gut are also the same ones as in your brain. We've all had the experience of feeling emotional and getting butterflies in our tummy, or before an exam having a slightly looser bowel. All of those things where our brain affects gut function is something which we're all cognizant of, and this idea of a second brain in our gut has emerged. And then, as you say, there is then the idea of practice, because the thing that's kind of important to us is the idea that it isn't just a command center in your brain driving your gut. There's as many messages going from your gut, in fact more technically from your gut to your brain. Most of those neurons in your gut are actually afferent. So how do you know when you're hungry, when you need to open your bowels, when you've stopped going to bowels, when you've satisfied your hunger? You know all of that because you get those afferent messages. So there's a two-way communication up and down.
Interesting. So you trained as a neurologist, and I presume this is a subspecialty?
Yes, it's a niche.
Yeah. So how many sort of subspecialize in the country?
Very, very few. The disappointing thing, I'd say I've had 29 PhD fellows now, of whom one's stayed in the neurogastroenterology world. Most gastroenterologists are interested in becoming endoscopists and inflammatory bowel disease doctors and the like, and that's grand, that's understandable. It's superficially, in my mind, a more interesting career.
But you trained as a neurologist first and then subspecialized in the gastroenterology.
Yeah.
But you have a lot of gastroenterologists under your care doing PhDs, but then never.
Yes. Most of what I deal with is gastroenterologists and GI surgeons.
Brilliant. Okay, thank you for that introduction. You know the format, so the conversation that we're going to have is based on 3 questions. So if you don't mind, we'll go right into it. So what would you like to share from your area of expertise, which is so super specialized, with the general population?
Yeah, no, it's a good challenge, isn't it? I think the thing I would like to say is that gut symptoms are highly prevalent. If you look at what consultations in general practice look like, we know that about a quarter of what GPs see is related to your GI tract. We also know that the vast majority of those are for benign conditions rather than for chronic inflammatory or sinister conditions. So a lot of that is reflux, but a lot of that is abdominal pain, and a lot of that is constipation and what is labeled as IBS. So I guess for me, the thing I would like to sort of disseminate amongst the population is to know that whilst we all have a background level of gut awareness, if there's a change which is persistent, that is often something that we can do something about. Everyone focuses on the idea of, these 2-week pathways and sinister symptoms. And I think even, it's certainly very well known in the profession, but even I think, lots of commercials and adverts talking about the need to be aware of alarm features. But
sorry, the 2-week wait meaning cancer symptoms, and that's what you're saying.
Yes, blood loss, weight loss, those kind of things. But what I'm really interested in, again, and I think that's popular knowledge already, but what I'd like to persuade people to be familiar with is the idea that a change in your background bowel symptoms. So if you're somebody who's always had a bit of bellyache before you go to the loo, and that suddenly gets worse, or the pain is in a different place, or you're going to the loo a tiny bit more frequently, therefore experiencing the pain a bit more frequently, those things are worth describing to somebody, your GP ideally, or your pharmacist, or whichever place you get your first line health, because they will often be a signal of something treatable. This notion that all of this stuff is either terrible news, so you mustn't mention it to anyone until it's really late, or that it's something no one can do anything about. The large majority of GI symptoms fall in the middle ground between those two polarities, where often there's something simple we can do, not necessarily involving drugs, but involving changes in lifestyle or how we use the bathroom or the like, which actually can improve symptoms. So I think a large burden of people walk around with GI symptoms, hence the presentation in primary care. But I think a lot of that can be avoided. If I can one more other thing, the other thing I think I would really be keen to say is that...
Even an example, but yeah.
Well, exactly that. In chronic constipation is a really good example. So if you look at, we produced these 2 documents about 5 years apart called the Cost of Constipation, which looks at the estimated costs from of constipation, kind of very common symptom which all of us have had at some point.
What's the definition of constipation?
So, good question again. It's the question of either infrequent or difficult bowel opening. So, infrequent is fairly obvious, but difficulty is subjective. So if you say, look, for me, I used to go easier, but now it's more of a struggle, or it's more pellety, or I need to assist myself, or I have to take up funny positions, or it takes longer, or I don't feel empty. There are protean symptoms there. But if you look at the costs of that, are estimated to be well over £200 million a year. And prescribed treatments, non-prescribed treatments, but also presentations to casualty, second and third negative investigations, colonoscopies, CTs of the abdomen, when patients for the same symptom keep going back because they haven't had resolution. Now, that then bleeds into the second area of what I like colleagues to know, but in terms of being able to handle this better. So, but constipation, I think, is one of these really taboo symptoms. It's a bit of a Cinderella area. Patients are embarrassed to talk about it. They often feel it's something that they've done wrong. Well, actually, it's something about how their gut physiology is. They may have a solution by altering their lifestyle, but that doesn't mean that they did it wrong for that to happen in the first place.
So they're late to present, or they just don't present.
Don't present. They manage by buying things over the counter, or they, I have lots of patients I have seen over the years who will go through a working week without using the toilet because they just can't, and then they'll on Saturday night or Friday night take a ton of stuff and then just spend the next day close to the bathroom. And that isn't an anecdotal story. All gastroenterologists will have had seen scores of patients with that kind of thing, where they avoid school runs, avoid meals out, avoid shopping until late in the evening because they may have to use the bathroom or wake up an hour and a half early to do their toileting routine before they leave the house, whether it's for constipation or incontinence or pain reasons. So I think
a significant impact on the quality of life, really.
Yeah, I think one of the things that fascinates me in a more so generic sense about the area is that I think the gut is one of those organs where we all use it every day in a very direct way. We eat, we use a bathroom, and a lot of it is very public, how we eat, what we eat, socializing around food. Yet the kind of elimination part is very private and really very taboo. And both parts obviously influence each other, and people's feelings about one, like, I'm a bit constipated so I won't eat, or I've got diarrhea so I will eat this. And some of that is old wives' tale, some of that is born in fact, but the two then perpetuate, and what we end up with is a chronic situation where people often have chronic gut symptoms, chronic constipation, chronic diarrhea, and they're taking lifestyle changes around diet or how they lead their life, but they aren't helping, but they're sort of locked into that cycle of doing something.
Right. So they're not even getting the right medical advice. You're saying that this is all based on maybe old wives' tales.
I think before they even get to, because again, one of the things that we see when we do the surveys, or other people do surveys, should I say, is that patients often say, I don't know who to consult, because there isn't in the way that we are comfortable talking about lungs or heart or pain or joints, because they're kind of, they're not personal taboo things. Talking about our insides is more difficult.
More of a barrier for them to even present to their GP. Interesting.
And I think it's that sense also, beyond that kind of embarrassment factor, it's also the one about thinking that it's something I've done wrong. I mean, blood loss, obviously, it's an easier thing to present with, because that's a sort of signal of something bad potentially. But I think those things like, I've got a bit of a loose stool, I've got tummy pain, or I've got bloated because I've gained weight. We often are keen to ascribe personal reasons for why that may be, which get in the way of
seeking help. And it's as equally prevalent in both male and females.
So, interesting question again. So I think in the places where most studies have been done, i.e. in the Western world, there's a female preponderance. But in those small number of studies come from sub-Saharan Africa and the Near East, it's clear that actually men are affected roughly similar proportions to women. So I think if you look at this statistically, you'd say there's slightly more women preponderance globally. Certainly in the Western world, there are more women presenting with chronic functional abdominal pain, chronic constipation, than there are men. But globally, it's probably similar.
Sorry, and I may have distracted you from your initial trail of thought, but you were going to give me an example, a practical example, about know what normal is for you and have a threshold of tolerance for what your symptoms are or abnormal symptoms are.
Absolutely. So I think one of the big things that we're keen on is that there's lots of myths around this, because we don't talk about it. Everyone assumes that it's normal to have a bowel action in the morning, every day, and it has to look a certain way, and it has to happen in the morning after breakfast. The reality is that only a third of healthy individuals have a daily bowel action. About a third have more than one bowel action a day, and about 40%, in fact, have less than one bowel action a day. Stool consistency varies from a sort of formed motion as a normal thing to normal individuals who have, for their normal is kind of a porridgey stool. Normal individuals who have a kind of pellety stool. So there's a huge range, and I think what we're keen on is for patients to recognize what their background.
That's not going to stay static, though, over the decades. Will your gut flora change as you age? And
so your gut motility changes a bit as you age, and your frequency becomes slightly less frequent and pellety as the decades go on. But as weeks to years go by, it's usually fairly constant for an individual. You're right that there is variation. And when I ask for the kind of appeal to think about symptom change, it's that thing which is more sort of persistent. The odd day when you've drunk a lot of beer or eaten a lot of pizza and you become more diarrhea-y or constipated, as the case may be, those things are to be expected. But when there's a change which is persistent, you don't expect it to wait for something horrible to happen, like the weight loss or blood loss symptoms, because most times those things are a premonition of something simpler, like a bit of malabsorption, which can be remedied, or a bit of pancreatic insufficiency, or, there's simple things.
What are these symptoms then that you're suggesting that people should keep an eye out for and then go to?
So it's a change
to at least
your
have
background.
a talk with. Change. Yeah.
That could be a change in frequency or stool consistency, which is persistent. It could be the development of abdominal sort of colic pre-opening or after opening, or after meals. So again, if you find that persistently after eating solids, liquids, I'm getting a discomfort in a certain part of my abdomen which is persistent, that may be an early warning that there's gallstone disease developing. And rather than waiting for that rare situation where it becomes a more sinister, dramatic gallstone, an abdominal ultrasound will tell you, yes, you've got gallstones, but they're never going to cause you trouble. They're just there, and they're a background factor. And actually then for that small number of individuals, still to head them off with a pass and say, there's a very small chance that these may go on to cause an obstruction, in which case they'll present like this. But knowing that, so that you almost can navigate your health from your gut point of view, rather than waiting to be ambushed by something horrible which you've sat on. So I think it's those things. And And the other thing about gut symptoms is that, from the most sinister type things like the kind of tumors and all that at one extreme through to the kind of benign end of the spectrum like IBS, the symptoms that you can get from those range of diseases that affect the gut is actually pretty similar. It's pain, it's altered bowel function, either too fast or too slow, maybe blood loss. But so in a crude way, anything from a pancreatic cancer through to IBS will have some version of those 3 or 4 core symptoms. What we're interested in is more the kind of nuance. What have you observed? Is it persistent? Is it waxing and waning? Is it related to meals? Is it related to lifestyle? Those things are much more interesting for us in terms of determining what to do. Because although what I specialize in terms of the sort of research and clinical area is that area of diseases where there is no organic disease in the gut, but there's an abnormality of how the nervous system controls the gut, it's clear that a good 10 to 15% of patients who present to me, even in a sort of tertiary care setting, have diseases. About 1 in 10 of those will find a problem which we can help with, which is not directly related to their underlying neurogastro issues. So there's a high prevalence of disorders can affect the gut. It's multiple organs.
Yeah. Can you give an example where you've been able to help somebody and it wasn't anything sinister, but it was
So the commonest thing, and I'll say I literally see this probably fortnightly, is somebody who ends up presenting with abdominal pain, chronic diarrhea, chronic constipation, who has underlying celiac disease. The idea that celiac disease, as we were taught,
and diarrhea is opening your bowels?
Diarrhea is opening your bowels to excessively frequent or excessively loose stool.
And is there a figure per day?
So technically it's defined as a stool weight of more than 200 grams of stool a day. And no one obviously weighs their stools. So it's more, the actual clinical definition we use outside of clinical trials, therefore, is more about burdensome. That's an important fact that it's bothersome to you. Burdensome frequency or looseness. And there's a distinction between that and urgency. People will often, again, be embarrassed to talk about bowel incontinence and bowel urgency, and they often talk about diarrhea. So one of the skills that I would like to persuade physician colleagues on is to be comfortable asking patients a bit more detail, because most of us are too embarrassed to spontaneously say, I'm having accidents, but to actually say, actually, we'll call it diarrhea and then hope that you will explore that with me. Patients with pancreatic insufficiency, patients who've had a history of pancreatitis many years ago, but then now present with a kind of diarrhea type stool where that's the issue. There's a condition called microscopic colitis, which we used to think was very rare. Probably affects as many as 1 in 200 people, especially women with watery diarrhea as a presentation. There's a lot of that kind of stuff. Bile acid malabsorption, people who've had previous history of gallbladder disease or gallbladder surgery, really commonly performed cholecystectomies, run the risk of having a malabsorption of their bile, and that can cause a diarrheal type tendency.
Get it. Okay. So thank you for explaining that. You've gone through quite a few conditions as well, which is really useful. But you're saying that loose stool, sometimes it will just have a really simple reversible.
That's the key thing. And it's worth persevering and worth asking a few subtlety of symptoms, not just saying, do you have diarrhea? It's, okay, so what do you mean? Do you mean looseness? Do you mean frequency, like you were asking me? And if so, is it predictably loose, or is it variable? Is it alteration in color? Because if it's yellowy green, that's more likely bile acid. If it's sand colored, it's more likely pancreatic. There's a set of simple questions which all of us learned in medical school, but I suspect in reality we often just make a note of 6 times a day, loose, and that's all we'll say. But actually there's a bit more digging. And with constipation, it's what the patient describes. There's a difference between the symptoms of, say, slow transit, i.e. slow movement through the intestine, which are infrequent urge and hard stools, versus the patient who says, well, I get the urge normally, but I can't empty, where they have a rectocele, which is a bulge, often in women who've had children in the past, a bulge from where the rectum bulges into the back of the vagina, or an inception where the bowel telescopes in on itself when you're trying to empty your bowel. So you end up with going a small amount, but not fully, therefore, and then you strain to go more, but that makes the interception worse, and so on. So it's often a question of that, and then to tease out those symptoms. Yes, you can do it by examining, but you just ask the patient, what happens? How often do you get the urge? Okay, it's frequent. What happens when you're in the bathroom? Oh, I sometimes have to help myself with a finger. And asking those questions once you've got the patient's confidence, they'll often want to say something. So I think we're now bleeding into what would I like.
But it's encouraging on both parts, basically. We want to encourage the patients to be able to come up with this information, but also it's understanding that it's about teasing the questions out sometimes as well.
For each specialist you meet wants colleagues to ask every question in their domain.
But we have 10 minutes.
Exactly, less often. And I think it's that thing about thinking when somebody asks, my prejudice would be that talking about bowel symptoms is so awkward for most people that if they open that door, it's doubly harmful to the patient if we don't let that open it wider, because they've
been brave enough to come anyway and present.
You often will hear patients say is that, I did mention it, but no, they didn't. No, it just showed. So I stopped talking about it. And then they'll retreat to self-management, which can be helpful, but can...
Get it. Thank you. Thank you for sharing that. Are we done for the general population?
Yeah, I feel like I've sort of talked wider than the general population, but yes, I mean, that's certainly those good. Yeah, so be aware of what your normal is. When there's a deviation from that which persists, be prepared to seek help. It isn't always about looking for horrible things like cancers. It's often about something reversible,
and it's seeking help from your general practitioner in the first instance.
Yeah.
Okay, great. Thank you. So for the second level question, what would you like to share with your GP colleagues? So we've probably covered a little bit of it, but yeah, if you go into more detail.
So again, I think it's the temptation in general practice is to think, understandably, the limited time one has, and God knows I wouldn't be able to do it myself for sure. How do I exclude the sinister things that are going to be a problem? So there's a temptation, therefore, to retreat to a set of blood tests and a referral for cross-sectional imaging, ultrasounds or CTs, or endoscopies. So, and what...
Sorry, repeat this. So you're saying for GPs to be able to feel confident getting these investigations?
No, what I'm saying is that often the temptation when a patient presents with these symptoms is to think blood tests, imaging, endoscopy.
Okay.
And I absolutely respect the need to do that to exclude organic disease.
Yeah.
And I'm sure, and the systems and pathways that hospitals and GPs set up is often very predicated on how do I not miss a cancer or Crohn's disease or colitis. And the pathways are very good for that. What I'd like to persuade doctors, GP colleagues to do is to think about what happens how can you help the patient when the tests come back negative? Because again, statistically speaking, 95% of patients who go through these urgent investigations and these 2-week pathways for cancer are negative, 95% plus.
Wow.
The vast majority of patients who go through these urgent pathways, fortunately, are negative. Now, when you have that, what happens to the patient? From the hospital's perspective, they've done the tests and they have barely touched the sides. They're discharged back to the community with no care being offered. From the general practitioner's point of view, they've had a set of tests done which have excluded the nasty things, but often we have...
But that doesn't necessarily mean that it's not...
Exactly. In fact, patients are presented with symptoms. Some patients are reassured by the fact that it's normal. They've been given a label of IBS or something similar, and that's a relief. But for many patients, they're left with the thing of, I was bothered enough to raise this. I haven't actually had help. I've had the reassurance of knowing that I haven't got something sinister, but I've still got those symptoms. And I think and the problem is that we haven't got a pathway for how we look after those. And what I'd like colleagues to feel comfortable with is that attending to the kind of postgraduate sessions that are offered in terms of how to manage chronic pain, because...
Have you got any good resources or courses that you can recommend? Because I can put links in this as well. Yeah. So, I mean, we all know we all need to do CPD. GPs, I think they need to do 50 a year.
50 points, yeah.
So,
yeah, I mean...
So it's already inbuilt into the system.
Yeah.
But...
So I think the things I would point to in this kind of world would be the British Society of Gastroenterology has modules that you can access without having to be a member.
Oh, great. So free.
Mm-hmm.
Okay.
I think you have to register, but you don't have to pay. And then there's stuff on the UEGW, which is the United European Gastroenterology, which again you have to register, but don't have to require membership, which are learning modules, which you can access. Some of them are made by primary care colleagues. specifically for that.
And they've been vetted by you.
And vetted by much more august people than me.
But you've seen it.
But yeah,
great
they are
resources.
some of them. We produce some of them, but they are some. It's also about how to manage chronic diarrhea, how to manage chronic pain, how to approach the patient with incontinence in a sort of a gentle way. Because what do we tend to do for things like? I'm very engaged with incontinence as a particular area, which I think is really badly managed. First of all, remember that about 4% of healthy individuals, inverted commas, experience fecal incontinence once a month. Now that number is high if you're older, if you're over the age of 80, but
even all age groups, you're saying?
Across all age groups, it's lower, about 1 to 2% under the age of 50, but it increases after that. But overall, the data from a very large MRC study in Nottingham a few years ago was that about between 2 to 4%, depending on age group, under the age of 60, have fecal incontinence. So it's a very high prevalence, and it's a really desperately private symptom, but has a huge impact on people's willingness to not work from home, to engage in social activity, all of that stuff. And again, what patients tend to do, what we tend to generically offer them is, think about your lifestyle, maybe use Imodium, goodbye. And actually there's things that we can do often. Yes, the lifestyle stuff is important. Is it because patients haven't fully emptied and they're soiling afterwards? Is it because they have a rectocele, a structural thing, which is then leaking after they've gone? Is it because they are chronically constipated and got a bit of
overflow
type stuff?
So there's something blocking.
Yeah. Is there any of the causes we've discussed elsewhere for diarrhea, which are now causing incontinence? Is it a problem from having a sphincter trauma, which they never knew about from vaginal delivery in women? The commonest cause of sphincter damage is vaginal delivery. And people often don't know about it. In fact, the majority of women who experience trauma down there don't know about it until postmenopausally, until 20, 30 years after they've given birth. So there's lots of things which will help explain that. And loperamide is absolutely helpful, but there are other things that can be done. There are things we can use inserts for patients to resist soiling. There are use of other medications like ondansetron, which can be into sort of a different.
But by this time you're saying that at least if the GP has picked it up, they then can refer to you, or this is still something that they manage in primary care? Or you or another gastroenterologist?
I think a pathway locally which says when patients have a problem with incontinence, do this first, think about the following workup, and then
be aware of it. So basically, as you were saying, that the first and the second point are interconnected.
Basically, a willingness to talk about it, a willingness to probe about it as professionals, knowing that there is something you can do. I think the thing I would say when I came into this space is that there was a lot of nihilism around this. People thought, oh God, IBS patients, constipation patients, oh God.
So why did you think differently?
I don't know. I'm a needy person who likes to be liked. I think it's a patient group who are orphaned. No one's really interested in them. I think there's a element of that actually in that population when no one's really interested, you can do simple things to make people better. It's not about, so the things that we publish on are sort of fancy electrical stimulation and stem cell stuff and physiological change and all this. But the reality is the majority of patients I see and try to help.
You can give them some practical advice. Things. Yeah. You can get them going.
So the basis on which we do any of the complicated things is making sure the simple things have been tried first. And honestly, hand on heart, I would say of the sort of 600 referrals a year I get, I expose maybe no more than 40 or 50 a year to our complex therapies, the vast majority.
Complex therapies meaning surgery?
So sometimes surgery, but often the nerve stimulation technologies we're looking at.
Fine. So the others are really conservative. Would you classify them as conservative measures?
90% of what I deal with in terms of new referral patients is going down conservative pathways, which will help many. Some will say, oh, I'm not doing that. I'm going to go, I want an operation or whatever else. And we say, it's not the right thing to do.
So sorry, just in case a general population person is still listening to this, even though in the GP. Can you just define what conservative management means? So they don't need to be scared, basically. So it's quite reassuring for me to hear that.
Doing the right lifestyle things, where, and that'll differ according to the primary symptom, using simple medications, some of which are non-prescribed over-the-counter things, some which are prescribed. I would include things like, so there's a treatment called transanal irrigation. Sounds very interventional, but actually once a patient is trained to do it safely, they do it themselves with just us in the distance in the wings if needed, which is basically like catheterizing, but instead of doing your bladder, you do it for your bowel, and you then use that to eliminate promptly and more completely so that you are voided without any risk of incontinence. And doing those things would make, even in my neurological
Your
cohort,
patients.
90% of patients will be made better with that. It's a very small number who need more complex intervention.
Okay, thanks for that.
Yeah, no, I think for me that's a really big deal, because I think that, so there's this sort of culture of nihilism which emerges, thinking, oh, well, these people are, I think the lazy things, I know many colleagues don't have that, but I think there's a pervasive thing, I can see it in the training that colleagues get from medical schools and nursing schools, that patients with functional disorders are a bit of a heart sink. It's hard to make them better.
I wonder whether that's because we have nothing to offer. It's a mirror more of how I've got nothing to offer you and I'm failing, perhaps.
I mean, I think we have these dichotomies in there between something wrong with your body, which I can fix.
Yeah.
Trained to.
And that's my job.
That's my job. Or something
Give it
wrong
to
in
me.
the brain, which is your fault. Well, actually, it isn't.
And
The
I
brain
can't do
gut
anything
thing.
about it.
I can't do anything about it directly, but actually maybe I can, because I can help you cope with the symptom and show you the boundaries of what you're able to do. I can normalize this. I can demythologize some of the things that you worry about.
So it's about reframing it, perhaps, with the clinicians.
Yeah,
They don't
without
feel so
involving psychologists. So of course I'm lucky to
Yeah.
have psychologists and hypnotherapists who are part of the team and a core part of the team, but they don't. It's not like a question of saying, oh, well, I've got organic disease, I'm going to shove you over there to somebody else to sort you out. It is genuinely thinking about this in the round, taking a holistic view on this, which actually is not just seeing yourself as the diagnostician and the interventionalist. It's actually about, so I'm going to sound very, very cheesy now, but I do genuinely believe the idea of caring. I think it's not just going through an algorithm of, okay, I've ticked off these and I've made sure I'm not going to be sued. It's actually about caring about the patient's outcome, and therefore recognizing sometimes that you can't help. So a lot of functional patients we'll see.
What do you mean by functional?
So disorders where there's nothing particularly wrong with the organs that we can see, but where we know that it doesn't work for them. So that your gut looks normal, or the nerve tests even are looking normal, but for you it's creating chronic symptoms of discomfort, bloating, pain, and we would call that a disorder of function, i.e. it doesn't work right. And unfortunately, we don't have good tests for how things work. We're great at looking at when things are infected or when things are lumpy or missing bits. Scans and things like that are great, but tests of how things work, especially the gut, most of which is, it's a great long tube.
Is it correct in saying there's no medical reason? That doesn't sound right to me. There's no diagnosis that we can make at the moment. Does that encapsulate it better?
I think it's sort of what people call medically unexplained symptoms.
Okay,
it's that idea that, we can't give it a label. But remember that things like pancreatic insufficiency I mentioned earlier on, they are often lumped as functional. Patients with IBS have turned out to have bile acid malabsorption in large numbers, turn out to have.
So the more we know, the more we learn, the more we practice,
Correct.
We're actually finding the reasons behind this. So now we're giving them more.
So the kind of that functional box
Yeah.
gets whittled out.
Yeah.
And that's the thing I was saying earlier on, about 10% of people who are referred to me as a tertiary specialist, we will find a cause.
Yeah.
Not because we're brilliant doing some esoteric tests like House on TV, but more because we're just doing simple logical things triggered by their symptoms. So yeah, this is a satisfying area. To answer the question you asked me sort of personally, why do I like this area? Probably because we're able to help, sometimes by doing something obvious, often by doing something simple.
It's the same with my area.
Yeah.
Back pain, everyone gets scared about, shoulder, rotator cuff adhesive capsulitis. But, if you can treat them, you can diagnose them, you can explain things.
Yeah.
That's often more than 60% of what the patient's looking for.
Yeah.
Yeah.
No,
Really satisfying.
I think that's something that probably comes on to the third part, which is, feels very natural, this conversation.
Good.
Of actually what specialists, lots of gastroenterologists are, I wouldn't say terrified because they'd resent that, but I think they're a little bit wary of the, in inverted commas, functional patients. So the patients who have had these negative tests
So no medical explanation currently, and that's what I want to emphasize.
Absolutely.
Because maybe in 20 years' time we will have more of a...
Exactly. So they've done these tests via their GP, which are negative. The patient has had the courage to then come back and say, yeah, but what is wrong with me, doc? And the GP says, I don't know, I will refer you now for an opinion. So they finally scale those waiting times for the investigations, then the waiting time to see the GP, then the waiting time now to see the specialist. They finally got there, and the doctor is thinking, well, there's nothing wrong with you. They've done these tests. I'm not going to repeat them. I will try and think of a placebo, inverted commas. I'm not trying to be disparaging to colleagues, but I see this so often that I recognize that it's, and I understand the anxiety. I would have the same anxieties if I didn't have the resources I'm lucky to have. But I think it's a thing of thinking, rather than thinking, what is the least I can do to get this person out of the room? It's more about, I would say, what does the patient want? So the question I most often ask patients is, if I gave you a magic wand to wave away one symptom, just one, you can't say I want to be normal again, what's the one thing that would make your life better? And it'll be often, I want to be less bloated, or I want to be able to go to my daughter's wedding this summer, or whatever it is. There's often one thing, and then, okay, that's good, something I can work from. It's that probably the same as your work, where you
I ask that too,
right?
Because they'll come with neck pain, back pain, shoulder pain. I'm like, no, just one thing. What one thing can I do?
This state that I can do something about, and then break it into bite-sized pieces and work from there. So I think for me, and I think I would say is that, especially where the label of IBS applies for specialists, IBS is a pain syndrome. IBS is not it's you had negative tests and you've got to complain. Lots of people who are labeled as having IBS don't technically have IBS. IBS is very strictly defined. There are 3 things you have to have. So this is for the kind of specialists. Okay. Number 1 is you have to have pain. Discomfort doesn't cut it.
What's the difference between discomfort and pain then? So
it's very subjective. But if the patient says, it gets a bit niggly and it's a bit of a nuisance, it happens in a long time, that wouldn't fit an IBS box. Okay. If they say, I have pain, and they have to have it for at least 3 months, so it's a chronic pain, and it's a pain which is burdensome for them to come and see you. Number 1, pain. Number 2, an alteration of bowel function. Either it's too slow, doctor, or it's too fast, or it's too frequent, or it's too loose, or whatever it is. Number 2. And number 3, and this is the most important one, I think, and you have to have all 3, is a
3 months.
For at least 3 months, a temporal relationship between the pain and the altered function. In other words, when I'm constipated, my pain is worse, or when I open my bowels, my pain gets worse or better or whatever. There has to be a relationship in timing. Bloating and mucus and those are all optional extras. But the 3 core symptoms of IBS are that pain, altered bowel function, and a relationship in time between those 2.
I did not know that.
No, I think a lot of gastroenterologists would say to patients, you've got IBS, because what they mean is you've got some bellyache and some bowel symptoms, which are all over the shop, and you've had negative tests. So we know you haven't got Crohn's or colitis or tumours. We can just give it an IBS label. And then what do? We tend to say, try a diet. And there's good dietary advice from NICE or whatever else. And sometimes, again, it's, if you offer, and kind of very sort of topical thing for the last 5-8 years has been something called a low FODMAP diet, which is this diet which is low in fructosaccharides, oligosaccharides, disaccharides, monosaccharides, and polyols, basically the foodstuffs which cause fermentation or water retention in the lining of the gut. And reducing that, who will that help? Well, it'll help people who have diarrhea. It'll help people who have bloating to an extent. It'll help people who have post-meal pain. But it'll make constipation worse because it's taking water out of the gut. It'll make people who have non-meal related chronic belly pain, it won't help them because their pain is chronic pain, not related to meals. So I think this thing of, I've got to rebuild your IBS, and you may or may not have it in real life, as we've said,
and then put you on the FODMAP diet.
On the FODMAP diet and make constipation worse. And then patients say, I've got much worse constipation. I did my diet for 8 weeks and I was told there's nothing else I can do after that. I did go back and they gave me a laxative, but then that gave me diarrhea, because IBS patients are not that they're fixed constipation or fixed diarrhea. So they're a bit of a hair trigger. So where you and I will get some variation day to day, week to week, as you were saying earlier on, and it'll fluctuate a bit according to what we've eaten and what our mood is and which phase of our menstrual cycle we're in. But for an IBS patient, those changes are much more delicately triggered and then much more profound when they do occur. And so giving them a laxative or giving them a loperamide to speed up or slow down the bowel may, not always, but it may just switch them too far the other way, and then they get the brakes slammed on and they become really constipated, or they get terrible trots after using a laxative, and then they lose confidence in what they can do. And because of that, back to that personal nature of the symptom, they then think, oh, I can't leave house. I'll not take laxatives except for the weekend, or I won't take Imodium because it makes me very bloated unless I absolutely need to, and I'll live with this diarrhea in some way. So I think I see in gastroenterology a lot of missed opportunities to help people. Not everyone. So I'm not saying that there's a sort of a panacea and that it's all go out there and find patients and you'll make yourself happy. But I think there's a group of patients who we just need to ask things a little bit more, probe a little bit further, and then as specialists think a little bit more about what is IBS, what is not IBS.
What causes IBS?
So there's almost certainly multiple mechanisms. It's that the reality is that the actual prevalence of true IBS is probably maybe one person in my estimate, about 1 in 12, but it's probably 5 to 8% of the population. Figures would quote it much higher, but I think if you actually look at strict definitions that there's a pain in all things we've said, it'll be nearer 1 in 20. And I think for that population, it's clear that there's a problem with excessive stimulation from the gut. So is that triggered by having excessively sensitized gut post-infection from certain dietary things that you do? And alongside that sort of peripheral hypersensitivity, there's a central brain increased perceptual change that's been shown physiologically in all sorts of funny imaging studies, where your brain is too sensitized to pick up signals. I remember I was saying earlier on, we use our gut all the time. We're eating, we're salivating, our guts are peristalsing and contracting through. And so there's always signals going from our gut to our brain, but most of that information is gated out. Your brain has got too much else going on to notice it. But if that's why, we've all experienced of thinking, well, you're a really busy day, God, I haven't eaten all day, and it's sort of 6 PM because you've just been so focused on something else, your brain has gated out the signals. Other days,
Gated out, you're saying.
Yeah, you're just thinking, oh, I'm sitting here and I'm bored and I'm waiting for somebody to arrive, and I'll just go to the fridge and I'll, and that your point is your brain is a very powerful organ at turning up or turning down the amplitude of signals from you. And in IBS, there's this. So all the things that have been shown to be factors like traumatic life experiences in childhood, or infection, or prolonged antibiotics, or altered diets, or stress, all of those things are altering physiologically either too much sensitivity coming up from the gut or too much reception occurring in the brain, or both.
Okay. And what are the treatments that you could offer true IBS?
For people with true IBS, it's trying to identify triggers if there are such a thing. Patients have often tried, but they often get a bit, when you're living it day to day, it sometimes almost helps to have an external person, a nurse, a doctor, a pharmacist, just actually interrogating this, because I often feel that one of the roles we have in professional practice of this is to almost be like a mirror to the patient and say, look, here's what you're actually doing. That isn't rational. You're avoiding all of this, but actually you're still getting symptoms. So first of all, identify what are true triggers and don't go with false triggers, which kind of old wives or magazine stories saying you should take more fiber. So a classic thing, take more fiber for constipation. Actually, that'll make a lot of people's constipation worse if you have slow transit. Certainly if you have slow transit, which we said earlier on is infrequent urge or hard stools, reducing the amount of fiber in that, like the low FODMAP diet, will make that kind of constipation worse because it gives you less to work against.
Sorry, explain to me I'm not as intelligent as you, but with the FODMAP diet, you're decreasing the water content of?
The various foodstuffs that we have, which basically retain water in the gut lumen. So that
so it's a drier substrate that's going through your gut.
Exactly, and less fermentable, so less bacterial activity. So therefore, you'll get less gas distension, you'll get more formed stool. So if your problem is bloating and diarrhea, it can be a very useful treatment for about 1 in 3 patients. 2/3 of them won't. And certainly, but if you have constipation or non-meal related pain, it won't help with that at all. So I was about 5. Yeah, so the lifestyle things. So identify triggers and identify, equally importantly, the false, i.e. the non-triggers. So that's part 1. Then number 2 is trying to engage in, a lot of patients have problems with, so to be blunt, with toileting. They tend to either ignore the urge because they're too busy and can't get time. And actually,
When the urge
if you're
comes.
healthy, you have the luxury of being able to ignore the urge and find a time. But if you have this vulnerable gut, you can't afford to miss that bus, because if you miss the bus, the next one won't come for a day. And then by which time your stools have got harder and drier and less likely to give you an urge. So you actually don't even notice the bus, and then becomes 3 days. And the vicious circle is perpetuated. And the other side of that is when you do go to the bathroom, then what are you doing there? Again, something we find awkward to talk about sometimes, but patients sometimes are sitting there straining in their throat and their neck and going red and purple in their face, but actually not concentrating their efforts on the abdomen. Or they sit there for such a long time that they get straining and hemorrhoids and prolapses and the like can happen really painfully often because they're not straining effectively. So actually a lot of what we do is help people do toileting advice, like everyone knows about the stool, like putting a little stool to raise your knees above your hips, do a more squatting position on the toilet, so that that helps open up the pelvic floor and relax the anal sphincter more, so that you can void more naturally. Leaning forward slightly. I mean, water is an interesting thing. People assume that you can hydrate your way out of constipation. You can't. I mean, if you're chronically constipated, I mean, if you become dehydrated from an acute thing, from running a marathon or something, of course your bowel will slow down. But chronically constipated patients, you can't selectively hold on to water in your gut. Most of the water you drink is absorbed, dealt with by your kidneys, and passed out. There's no way of magically holding that water in. So people will often drink and drink and drink and say, my bowels aren't any better. It's not like a magic wand to make your bowels work, because you can't hold on to it where you want it to. So again, it's about, as much as sort of false triggers, there's also false treatments that we often indulge in. And often again, tell people, don't torture yourself by drinking 3 liters of water a day. You're just making yourself go to the loo more often and spending pennies without actually making yourself go and getting more frustrated, because each time you sit in the loo to try and pass urine, you think, I'll try and push my bowel. Oh, that didn't work. So I've had another frustrated attempt. My bowel's really bad. So a lot of it is about taking away myths and misconceptions. That's a really big part of this. And then the direct things, there's a really strong evidence base for gut-focused hypnotherapy, and increasingly hypnotherapy doesn't have to be delivered by a person. There's online versions. There's lots of interesting ways of accessing. Lots of specialist hospitals know that they can't cope with the volume of patients, so they've created modules. There's apps.
And they work, so they're evidence-based.
They've been put through randomized clinical trials and shown to work. So there's stuff out there for this patient.
So a patient, even if it's going to do no harm, correct?
Yeah, it'll cost you a bit to get the app, but some of these have been commercialized, but but
it's worth the trial.
Randomized controlled trials show that they work better than the sham arms of therapy. So there's that. Again, tailored diet. So low-FODMAP appetite for every IBS patient? No use. Tailored to those patients, as we mentioned, with diarrhea and pain after meals or bloating, very helpful. And the sort of biofeedback to basically help you relax your pelvic floor and sphincters and empty more completely, incredibly helpful for patients who've been often mislabeled as IBS, and actually they have a problem with their pelvic floor evacuation. So there's a good deal you can do. So not every IBS patient is going to be cured, but a lot of those ones who've been labelled as having IBS have something treatable.
Chances are
Stuff or balance it. And that's maybe 5-10%. But of the rest, there's often some bit of physiology you can reverse. The reason a neurologist, so go back to the beginning of all this, gets interested in this is because the physiology of gut function is strongly dependent on nerve activity, and tweaking some of that nerve activity is what we want.
Well, that's such lovely symmetry. I almost want to end it there. But one last question, if you allow me to. Or more of a comment, because I deal with, as a sports and exercise medicine consultant, lower back pain. And I'm telling my patients, speak to occupational health, see what modifications you can get. But as you were talking about, not wanting to miss the call to go.
Mm-hmm.
What do people do at work, And they're not going to ask for a modification from occupational health saying, I need to exit this. I mean, I told one patient, you've got to get outside every day at 11 o'clock for your vitamin D for 10 minutes. She's like, I have meetings then.
Yeah.
I'm like, okay, loosely speaking, just get out whenever. But if you're stuck in a meeting, you're not going to be able to do this. It has a real impact on your quality of life, eh? And yeah,
For sure.
it's more of a comment, but do you get occupational health input for younger patients?
Yeah, it's interesting, isn't it?
I mean, they're going to be embarrassed. They
it's
can't
so
even...
awkward.
Yeah.
Exactly. I mean, dealing with talking about back pain,
Yeah, it's acceptable. It's musculoskeletal.
Exactly.
Or it's a weekend warrior injury that they're quite proud of.
Exactly. Whereas this stuff is often, I probably began, and people often sort of find inappropriate triggers. Think, it's because I got drunk that time and I got this, or it's because I had that infection and then I took this, or I took antibiotics for too long and I shouldn't have done. People often, there's a lot of guilt which goes with bowel stuff. And digestive stuff generally, because back to that thing, we use it all the time. We do formalize it. It is how we eat and how we go to the bathroom. And so people often, and it's tempting to think, I am what I eat and all that kind of stuff. And everyone's aware of obesity and all these things that we're so all constantly thinking, oh God, am I? So there's a lot of personal angst that goes into our guts, and am I eating clean and healthily and all this? And I should be eating organic food. I should be getting this, the supermarket's own brand, and that's the source of guilt. And all this about, it's certainly true that the most deprived communities are the ones who experience the greatest burden of symptoms. And there's certainly an aspect of lifestyle and diet which is a factor, and that's not the only factor. But then the willingness to suffer in silence because you can't afford to take time off from your caring or your 2 or 3 jobs that you have. Now, this is, I'm getting a bit I get a bit overwhelmed by what people go through, but I do think there's a huge burden that people carry with gut symptoms, which they don't always carry in the same way in my sort of neurology practice. Of course, things like MS and spinal injury involve the whole family, but there's an acceptability, I think, as you were saying, about the things that causes, whereas patients with a primary gut illness, which is, inverted commas, functional, often have that sense of, and it made it even worse if the doctors or nurses looking after them and say, well, it's nothing, there's nothing wrong with you. It's sort of alluding that it's in your head, inverted commas, and then think, oh God, that's really awkward. People are going to think I'm malignant. So I think there's a sort of a...
No, but thank you for coming to raise awareness. And hopefully we'll be able to share this recording with many people. And even if we help 2, 3 people through this recording,
It's worth it.
I think, we've succeeded. So thank you for taking your time to come all this way to share your pearls of wisdom. And thanks for being such a great clinician as well.
It's kind of you. Thank you ever so much.